Can I welcome members, invited guests and the public, both here and watching on the webcast, to today's meeting of the Health Committee. Our main topic of discussion is eye health and eye sight loss, and we encourage anyone taking part in the discussion on social media to use the hashtags #AssemblyHealth and #SightLoss. First, we have a few short items of formal business to go through before we get to to speak to our witnesses. First of all, I have apologies from Fiona Twycross, who's being replaced by Assembly Member Liam Cooper, and also from Assembly Member Susan Hall, who sends her apologies. Can I ask members to note the list of officers set out on item 2 of the supplementary agenda table at today's meeting, and also ask members have any other interest to declare? Can I ask members to note the membership and chairing arrangements set out on item 3 of the agenda?
Noted.
Can I ask members to note the terms of reference of the committee set out on item 4 of the agenda?
Noted.
Thank you. Can I ask members to note the standing delegation outlined in item 5 of the agenda?
Noted.
And can we confirm the minutes of the meeting of the committee held on 19th of April 2017 to be signed by me as correct record?
Agreed.
Okay. Can we note the completed and outside actions arising from previous meetings?
Noted.
Okay. Can the committee note the recommendations as highlighted in item 8 of the agenda? Thank you. Well, that brings us to today's main item, a discussion on eye health and sight loss. First, can I ask members to agree the focus of the discussion? The current landscape for eye health in London, looking at how all Londoners can be supported towards better eye health and protected from avoidable sight loss. Whether a London-wide public health response to this issue could be improved diagnosis and treatment outcomes. The role of the mayor to support the aims of the National Vision Strategy, and also how the mayor can support the better eye health through the Health Inequalities Strategy. So can I please welcome the guests for this morning, Dr. Parul Desai, ophthalmologist and consultant in public health, Moorfields Eye Hospital. Welcome. Helen Lee, advisory directorate of the Royal Institute for the Institute for the Blind. Welcome. Kathy Lau, London project director of the Thomas Pockleton Trust. Okay. And also David Perkins of the who's the optometrist and chair of the London Eye Health Network. Yeah, thank you, welcome. And Keith Valentine, Chief Executive Officer of the Vision UK. Okay. So welcome to all the guests. I may direct some questions to specific people, but if any of you feel that you want to chip in and add something to contribute to any topic, or any of our members ask questions, please feel to do so. And so we look forward to a very productive discussion this morning. Just to set the scene for everyone, can you tell me, we'll start with you, Dr. Desai, what are the current trends in regards to sight-threatening conditions in London? And why, and have those trends changed over the last years, and should this be something which we should be worried about in London?
I think the picture in London is not dissimilar to other parts of the country. The short answer to your question is that the trends are all rising in terms of conditions that pose a threat to sight, as well as those conditions that may not necessarily cause a threat to sight, but nevertheless impact on the overall vision and the eye health of an individual. And the reasons for this are that the main determinants of sight-threatening conditions are, on current evidence, ageing and a consequence of chronic diseases affecting general population health, so diabetes, cardiovascular disease, obesity, all the usual things that you would we hear about for general population health. So as all of those are rising, we're going to see big numbers. So whichever way you look at it, the numbers are going to rise and they're going to be big. We're not saying that eyes are any different. What we are asking for, I think, on behalf of my colleagues, is that eyes, our eye health and vision is not overlooked in the broader health priorities of the Health of London.
Thank you. David, did you want to add something?
Yes, I would totally agree. We would agree with that. I think the challenges are that we've got an ageing population, but we've also got new treatments that we can do for people to prevent deterioration. And I'm thinking particularly in age-related macular degeneration, glaucoma, diabetes, which we'll mention some success stories in that later. But the picture is the more that we can do, the more resources that will be needed to achieve this. And over the last 10 years, there's been a 40% increase in hospital activity, 30% over the last 5 years. And that does present challenges to clinicians who are working extremely hard to manage the numbers in very difficult circumstances. And we have to be mindful that when we say that there are delays because of the system and delays for people already in the system, that there are clinicians on the front end of this doing their level best to make sure people are seen. So it's what support can be put, extra support for those doing a really challenging job.
Thank you. And maybe the next few questions are towards Helen, Kathy and Kate. What impact do poor eye health have? So what impact do poor eye health and sight loss have on the wider health and well-being of the well-being issues of West London? I mean, what's the impact of this?
Well, I think in terms of obviously there are significant impacts of living with avoidable sight loss. I think there are some things that it's worth us being aware of in terms of the impact on the health system and the additional burden, cost, as well as the kind of burden on individuals. But the issues like falls, actually by failing to have to put enough focus on access to primary eye care services and integrating eye care into a wider health services, what we're finding is that the patients are coming in with falls that could be preventable had their eye condition been addressed. And of course, falls leading to bed blocking has a much wider impact on the health system. I think issues like dementia, there are links between sight loss and dementia that we need to address, because actually if we address people's eye health needs when they're experiencing dementia, that will actually help in the management of dementia and their life and living with dementia. There are issues around people with learning disabilities with a much higher prevalence of sight loss. And again, their quality of life, their experience can be much improved by simply addressing issues like refractive error. So I think that the reason I would particularly mention those issues is that there's a real issue about if we improve the eye health services, it'll have a wider impact on obviously people's lives and well-being, but also the health service. I'll probably leave kind of the experience of sight loss to others.
Well, being a Londoner that was diagnosed with sight loss and then working in the sight loss sector, I can't really escape the issue. Londoners, I think, diagnosed with sight loss it's a high impact event on people's lives, and the transition from that diagnosis through the various pathways to support are absolutely critical for the prognosis for someone moving from being a patient to being an independent person living with sight loss. Certainly for the working age population, there's about 75%, give or take a percent, of the working age population in London with sight loss that are out of work. And given that technology is transformational, I mean, this thing helped me keep going. There are some key things to think about. Also, a lot of the mental health effects of a diagnosis of life-altering sight loss are very similar to the impact of grief and identity. And there is something about how we think about the structure of social care that would help people tackle those kind of issues that are more widely present in the general population, but particularly with sight loss. And we do find, I think, on occasion that people are not moving from a diagnosis of sight loss swiftly to the kind of support that would help them. And as we all know, with mental health conditions, it's wise to get the help as early as possible to have a good prospect of being able to cope. So there are things, I think, to be done, not just by public authorities and health authorities, but the voluntary sector as well, in making sure that transition point works well. And a good part of that is about information, I think, and helping people understand where they can go for help, but also to build the understanding amongst clinicians who are doing the best they can for the health of the patient, that there are places that you can go for that further support. There's also something on my mind as well that particularly in the London population, there's some work done at King's recently that was looking at the retinopathy screening. So people with diabetes routinely having their eyes screened to see if they've got diabetic retinopathy. And there were high percentages of that population that were showing up with unrelated eye conditions that maybe wouldn't have been caught if they weren't on the diabetic pathway. And what that says to me is that we may have Londoners out there that have got multiple conditions, and if the trigger point at which all the various conditions are understood can be through any of the pathways. But I think the particular thing about sight loss in that is it can directly impact their ability to function economically, socially, and in their own communities. Again, it's a transition point. It's how we make those things connect together to get the right deal for the Londoners, if you like, in their experience.
Well, I just really echo everything that everybody else has said. I'm sitting on the end, so I kind of do that quite often. But I mean, for me, it's really the emotional impact. And I've read somewhere that actually I was diagnosed myself when I was 13. So I think there's a whole issue around children and young people. Children and young people with sight loss are more likely to end up in poverty, actually, because of not working. But the emotional impact of being diagnosed with sight loss is actually akin to being told you've got cancer, which everybody can kind of really understand. And I think that there's the preventable sight loss, and then there's the sight loss that isn't preventable. And it really is about having the kind of emotional support there that's joined up to, because there are sort of success stories, and Keith and I probably are success stories because we've carried on working, and there is support, there is help out there. But it's just getting that at the right time, and the timely intervention and things being joined up, actually.
Dr. Desai,
just briefly to say, I think vision and good eye health, influences everybody's experience throughout their life course at all ages, all levels of society, and involves all levels of health and care systems. But I think I think definitely speaking to patients or who tell me that there are different levels of sight impairment and how it can affect individuals. So for all of us who think we have good sight and those of us who have mild to moderate impairment or even severe impairment, the key thing, as Helen has pointed out, is personal safety, accidents and falls. But also for those of us with good vision, or we think we've got good vision, or mild to moderate vision impairment, it's about driving and other personal safety and accident prevention issues. I think broader, for those who do have morbidity from sight impairment, there's this general drift from inclusion in society to social isolation, from independence to dependency, and all of the mental health issues that can arise around that, which can get overlooked, which others have already alluded to. And I think the other thing is that it's around maintaining your own health. We're not robots just yet. We don't just have one thing wrong with us, and so your vision is really quite central to how you maintain your own self-health, both your own empowerment, but also if you're self-management for looking at your medication, looking at the labels, taking your pills, knowing what to do, and making appointments, that sort of thing. So there's a variety of ways that vision and sight impairment and eye health affect the quality of life and well-being of Londoners and all of us, really, at all ages.
Given that eyesight, of course, is very, very important, but is there enough public awareness about it? People, they get a lot of information about diabetes, right? They get a lot of information about other preventable conditions, but do people still have enough information, right, about eyesight? Because I speak as a practicing doctor, right, that I do not see that perception, right, or
I'd agree. I think we all would. And I'll give you an example. One of the things that really astounded me, only really recently, was that diabetes, we know it's a health priority for across the board, London and the whole country. We know that it has serious sight-threatening complications, which can lead to sight loss. But, and we have a wonderful jewel in the crown, which is a diabetic eye screening programme in the whole of the UK. And that really is something to celebrate about within the NHS. But you would think that uptake of screening for diabetic eye disease would be a core care process. It was dropped several years ago. You will probably be well aware of that in the QOF. And I just found out recently that it's not even in the Public Health Outcomes Framework anymore. It's dropped. So a core care process which affects eye health, which is part of a health priority, is seen separately. So eyes are seen separately to everything else. And if there's one thing all of us would like to convey to you, I think, is that all right, is that eyes and eye health vision should not be seen in isolation of your broader health. Not at all. In fact, if you consider eye health and good vision in promoting the core public health messages that we already hear about every day, if they all have an impact, albeit long term, on your eye health further down the road. And so for the investment that you've made in your core public health messages around good diet, not smoking, exercise, all of that stuff, you're actually getting added value because you're going to get that investment in better eye health later down the line. And the similar...
Can I just ask what was the rationale at the time for dropping that particular module test?
For the QOF, I don't know is the answer for that or the public health outcomes framework. I don't know. It may be for a reason that I'm not aware of, but I can't answer that question.
Okay, thank you.
I think for the QOF, the argument was that GPs had minimal influence over uptake of screening. I think that's arguable actually, because I think we know that GPs can have a huge impact
They do.
on uptake of screening. But the public health outcomes framework was news to us all. I think
It was just blank for London.
Yeah.
I'm a bit. Can I just come in as well? Because GPs might have had a minimal impact, so the best thing to do was not to measure it at all.
Not to ask in the GP QOF, not to ask GPs to measure it, not to.
As part of the core care processes for a person with diabetes, there's about, you know better than this, about 7, aren't there? There are about 7, and screening uptake for diabetic eye disease was included in that package of care processes until about 4 years ago when it was dropped. I think it was 4 years.
It seems such a bizarre decision.
If I can ask you, but not, that is a mechanism for where doctors are given key performance markers, okay? But when a patient gets a letter, right, to go for diabetic screening, the GP has little influence, right, whether the patient uptakes it or not, right? We can remind them, but I mean, it seems rather unfair, right? That the people who are being invited and aren't taking it up, right, that the doctor should be punished for it. That was the rationale behind it.
But we surely, I mean, and I speak as someone whose father was diabetic and an ex-partner was type 1 and my father was type 2. So, you know, I've spent a lot of time hanging around in Moorfields, Old Street and at St George's, you know, waiting to, you know, bring people home after they've had various different examinations and things put into their eyes and all the rest of it, because obviously you can't drive after that. So I'm just astonished at what you're saying, because I can't think of anything, well, possibly neuropathy and ending up with amputation might be as bad as retinopathy, but it just seems mad not to measure it.
They are being invited. They are being measured.
But
we need to know that
but separately.
Yeah, but separate, not part of the cough, right? But it is being measured.
So diabetic eye disease complications and complications are considered and reported separately to all the other care processes that a person with diabetes should be receiving and you know.
Do you have any figure on what is the uptake of diabetic retinopathy?
In London, I do actually. In London, it is around. I'll tell you. Can I just look out? In London. So the 2015-16, the London Diabetic Eye Screening Programmes do report that, and there's an annual report nationally as well, and they contribute to that. There are about 300,000 people in London annually who are offered eye screening, and that's offered to people who are 12 years of age and over and registered with a GP. So therein is already a sort of an issue. Overall uptake in London, most recent figures would suggest it's around 82%, which is consistent with sort of the national figure. But within that, there is variation within London, which I think would be why we're here today. Is that so? You could have somewhere like a CCG like Richmond has 89% uptake, but then you have Tower Hamlets and West London CCGs who have about 76% uptake. But then, so we go, oh yeah, we know why that is. But then you look at other CCGs such as Newham, Redbridge and Havering, who actually, according to the report, have uptakes much closer to the London figure, overall London figure, or higher. So I think when we're talking about uptake of health, or particularly the screening, it's not just the usual demographic factors that are operating here. We do need to look at this and drill down as to what other factors are operating here in health-seeking behaviour. And again, that's where maybe this could be a clue to other areas of chronic disease management, that eyes could inform the wider health picture.
Well, this very conveniently brings us to the member for Newbury, Newham, right?
Newbury.
Thank you, Chair.
Mr. Snyder, right? Who's going to be exploring this even in more detail, right? Or why his boroughs have such variation.
For diabetic uptake, retinopathy uptake, you're doing very well.
Okay. Some good news. Chair, I have two sets of questions. The first set of questions is to you, Dr. Desai and Mr. Parkins. Which groups are particularly affected by sight-threatening conditions in London and why? And also, how variable is access to good eye health support across London? So, three things there. Which groups are particularly affected by eye-threatening conditions, why? And in terms of access to good eye health support, how variable is the pattern across London?
Well, certainly looking at age-related macular degeneration, the elderly population, this is an area where more treatments are now available for the wet form of the disease. And this creates significant challenges within hospitals because of the regular appointments that are required, probably 3 monthly, and then they're monitored thereafter to have subsequent injections. And then there's also glaucoma, where certain groups are more, the prevalence is higher. And once you're diagnosed with that, then you've got lifelong treatment, so it's really a chronic disease. And I think coming back to the system, where there's nowhere else to see these patients at the moment except the hospital. And so the challenge is, as more are detected, more need to be treated, and it's a treatment often for the rest of your life. And it's how we can manage that in a way that we can make sure that everybody has had the treatment that is necessary within the timescales. Mm. We are fortunate at the moment in this current year that the NICE groups have been looking at cataract and glaucoma, and in the next few days, draft guidance for wet age-related macular degeneration will be coming out, and this is out for consultation, which could well reset how services are delivered and commissioned for the future. I sit on the NICE group at the moment, and we've been looking at that in terms of avoiding referrals to avoid the capacity issues, and also enabling people to come out of the hospital in a safe way. So there are things taking place at the moment to make system improvements. But cataract is a particular issue in London. There are thresholds being looked at to restrict access to cataract care, which I think this has been publicised, and the new NICE guidance has said that there should be no restrictions on cataract surgery because of the visual acuity thresholds. But that's still in draft at the moment, but we'll see what comes out later in the year in the true guidance.
And the vision could be less than 679, isn't it?
There was a London VA of 6'9"
Yes.
in each eye across London. That has been taken up to in some areas. The driving standard is 6'12", but it has been higher in some areas and also has been limited on second eyes as well. So there are...
So there is a variation between London
Absolutely.
of CCGs putting different conditions,
Correct.
some different VA visual acuity limits, right, when you can have access to therapy.
So there is there can be a postcode lottery depending on whether the referral threshold for your particular commissioning area is restricting treatment.
In terms of vulnerable groups, I think, and for sort of more at risk of inequalities in health, I think there would be the same groups who would be affected as for broader health, as for eye health, and that's would be the same things. And I think, again, it's about making sure that inequalities are not just looked at by conditions, but holistically, because it's a person, and so you don't just look at them for their hip or their eye or something else. They're the same groups of people. There are common things that are predisposing them to health inequalities. I think, if I may, is suggest another way of looking at inequalities, given the sort of discussions we've had and what's topical in the NHS regarding capacity and pressures within the whole system, not just in hospitals, but across health and social care at all levels. And that is capacity. And I think for eye health, which is really dependent on secondary and tertiary prevention to maintain vision and prevent progression and sight loss, progression of disease and sight loss, I think capacity issues are a public health problem and a system-induced inequality that affects everybody. And also it's looking at it's not just demography, it's a system-induced thing. And so if you have pressures on capacity to provide services, you've got inequitable access and availability to services across the board. There are issues in terms of effectiveness and getting good outcomes if there are delays. And similarly with delays or not having timely intervention or timely assessments, you have a potential patient safety issue and risk of harm to the patient. So for all of those reasons, I think for eye health, the capacity issues in the health and care systems are a core public health priority.
Two questions, and just to all of you really. How aware are people of the importance of maintaining eye health and how to do it? And what are the main barriers to raising awareness?
So I think in terms of the barriers to accessing eye care, we've done quite a lot of work in parts of London with different communities, and I think one of the really key issues is that the eye care pathways are fragmented for people. So initially, access to eye care is through the opticians. There is obviously a retail dimension to optometry. We've certainly some work we've been doing in Hackney, for example, indicated that people weren't so concerned about the price of the eye examination, but the price of glasses, and concern about having to buy expensive glasses was a barrier for people. We found that once people have had a good experience with the opticians, they're then more likely to return and go back. But certainly that was an issue that really could do with tackling. People often see the opticians as actually, it's more about where you go and buy glasses rather than your eye health. So highlighting the value of eye examinations in terms of eye health is an issue that I think needs to be addressed. And then, as others have mentioned, going through, if people do have an eye condition and have to go into to get treatment and care, that system can be very difficult for people to manage. Often appointments can be delayed, and people have to chase up their appointments, that's okay if you're confident around chasing up your appointment, but if you're not, that can be really problematic for people. So I think the fragmentation of the system can be really difficult. And I've now lost the train of my thought, and I'm sure there's a different another part to your question which I can't quite remember. Sorry.
Well, I think awareness of maintaining eye health, how to do it, and the main barriers to raising awareness. But you touched on that.
I think actually going to the opticians, there's lots of information out there about the value of going to the opticians by the commercial outfits, but actually shifting that focus for people to know that an eye examination is a health check. I think that's where we need to do some work. I think there are some real issues about the commercial aspect being a barrier for people. And while we absolutely can encourage, and we would want, I think we'd all agree, we'd want eye health messages to be incorporated into other public health messages. And there are, messages around smoking cessation. Actually, if you talk about the value of to your site about smoking, that can be really useful. If we potentially have thousands of optometrists who could be talking about smoking cessation. There are obviously issues around that and funding for that, but there's a real potential there. So I think while there's some real value in talking more about the value of eye health, we also have to acknowledge what the challenges are. And as Carol has said, the capacity issue is something we really need to address.
I think it's certainly true that the bulk of the messaging around eye health that's got any humour or eye-catching aspects to it is coming from the private sector through the TV ads and whatever else that one sees, and absolutely that's seen as, you need glasses, get some glasses. I think there are questions that some work I've been doing recently and looking at how the voluntary sector clarifies its messaging so that it actually makes sense to the general population rather than just to the people who want to broadcast the message is a key thing. And I think there are things to learn from the way that social media operates now and some of the tricks, some of the marketing approaches that are adopted by the corporates in placing ads. But I'm still of the view that there's something that can be done cross-sector between public authorities, health and clinical colleagues and the voluntary sector to try and clarify some of these messages in a way where we're looking for a direct impact on people's understanding. Certainly I feel that there's a lot of kind of public health messaging out there about numbers of conditions, and it's quite difficult, I think, to clarify a message that's going to resonate with the population amongst all of the other messages that are coming through. And certainly, the impact of eye health is, I think, underestimated in the general population. In a way that it's not so much for diabetes because of there's an understanding of the risk there, if you like, and certainly with cancer, there's that switches on lights all over the place in people's thinking. But eye health is I think far more significant than people understand, and I think that there's certainly work to be done to start to get an understanding on the part of the professionals involved as to how we communicate that to the public in a way that makes sense to their own lives. There are examples of good work out there. There's certainly a lot going on in social media that's starting to help. But I think for London, there's a further step that we can take together in clarifying exactly what are the key things we want the population to understand about their eye health and how we're going to get that message out there. And I think it sits with all of us to reach for that.
Dr. Sir?
I think it's what Helen and Keith were saying is the usual catchphrase, make every contact count. That applies to eye health as well. What we're asking for is for the eye bit to be included in that message, whatever messages are going out, as well as Keith has said, whatever message it is, it's got to make sense to people. We're being bombarded everywhere about do this, do that, drink coffee one week, don't drink coffee another week. It's going to do something horrible to your hair will fall out. I'm being facetious, but you get all these messages about what to do and what not to do, and it's confusing, even if you're in the job like we are. So I think it's very important about is the messaging and the communication. I think it's not just eye health, I think it's everything. We're not very good at getting that message across in a way that makes sense to people in their everyday lives. And an example I would give is that glasses. I haven't got my glasses for me, but I do need them when the lighting isn't good to read. But like most of us, if you can get by, you get by. Now, in most situations, that's okay. But when I'm in clinic, I would wear my glasses because I can't misread something. But it's about knowing that just because you're managing okay and you have got an uncorrected refractive error, and that has implications on what you're doing. And there are risks associated with that. And a good example that would resonate with most people of all ages is driving. If for no other reason, you know, if you can't see well enough to meet the DVLA requirements to drive a car for social reasons, then it really impacts on your way of life in London. I know we're not meant to drive in London, I know that, but we still do. Or even getting on the tube, getting up and down the escalators, and, you know, and that's another thing we'll get onto. But it's that kind of thing. I think, you know, in the messaging, I think, is that what difference it would make to you. And so because you can just cope and get on, and because it happens slowly, you're adapting to how you manage. And so it's almost subliminal. So I think there are very specific reasons why eyes are different, but there are many more reasons why eye health can be packaged up really well within the big headline messages as well. And we would like to see that mentioned. That's really what the eye health community is asking for as well.
It's actually interesting that when you talk to people that aren't affected by sight loss, if I talk to people, they say they can't imagine anything worse than losing their sight. So somehow we're not getting the messaging right. There is messages for the general population, there are messages for people with specific conditions about treatment, you know, there are a range of different messages, and we've got to find a way of nailing all of those. And I think actually it does deserve an increased priority, because because of what it doesn't, you know, we have done, we sort of do sneak those messages in. You know, I know that the work that we've done across London, we quite often sneak messages in on the back of diabetes campaigns or smoking cessation. But actually, why shouldn't it have a higher priority?
Just comment. When they had the NHS 5-year forward view, there was no mention of eye health in there. And in the annual commissioning plans, eye health again is not in there. So it's not on anybody's radar to tackle it. Cancer, A&E waits, the hospital capacity, they're really at the forefront of what the priorities are at the moment. However, there is an allergy to eye health in all of this, because if you look at the system change, the waiting and in the hospitals is just the same for eye health, and somehow we've got to encourage refinement in primary care to avoid unnecessary referrals getting into the hospital. And there is a split in commissioning between NHS England, who fund the NHS sight test, and CCGs, who are responsible for commissioning the extra add-ons, such as repeat measures if there's suspect results, cataract assessments, and minor eye condition schemes, which is all part of primary eye care. Now in Scotland, that's all commissioned as one. In Wales, it's all commissioned as one, under one contract. Yet in London, only a third of CCGs are commissioning repeat measures to avoid glaucoma referrals, because if you measure it in a different way, you can get a more accurate result. Consequently, you get more false positives into the hospital system. Now, if that was commissioned once across London with one service specification, it would make so much more efficiency in the system, relieve capacity in the hospital, and just make it better for patients, because they wouldn't have the worry about the referral to know 13 weeks later that there wasn't a problem. And so there's so much duplication that's going on at the moment that could be done differently. And I've been in the NHS system for quite a while, and I remember when there was NHS London and they looked at the London stroke strategy, and you looked at the hyperacute centres and you looked at London as a whole, and you commissioned where there was need. And if that was done for eye health, and I had a go at it about a year or two ago, the London Eye Health Network did a Achieving Better Outcomes report. And they looked at the changes that could be made if you did things differently. Things could there's a better way of doing what we're doing at the moment. But it needs that London-wide view. They're already doing this in Manchester, where they've got Devo Mank and they've got an eye health strategy for Manchester. But I think it's coming to the time where in London we need that broad brush approach. It is happening, I have to say. We're looking at STPs, transitional and sustainable partnerships across London. We have 5. And CCGs, the local authorities, are starting to work together. But eye health is not in there as part of their priorities. And it's how do we get eye health into those collectives where we bring people together. I've started having eye health network, I've called them quality improvement programme boards in South East London, in North East London, and I'm working my way around. But we're getting the trusts, we're getting the optometrists, we're getting those people who are actively involved in commissioning, because they are key people around the table, and they're all trying to do the same thing. And I think there is if we can get it working on an STP area, that's the direction of travel. But they've all got the same challenges within London, and I think there is sharing needed the next step between the STP areas, because everybody's facing very similar problems.
And just to quickly ask you, Mr. Valentine, you did say that there were examples of good practice. Is that something you could forward to us or summarise?
In relation to?
Yeah, in relation to, you said along with social media, there's some good practice out there about getting the message about eye health out there. And we always like on the Assembly to see examples of where things work. Otherwise, we just moan about everything.
It would be great to forward you the evidence for that. I have to say I could attempt to describe the way that social media works, but I can't say that I'll necessarily give it justice. If I give an example, in London there's a condition called retinitis pigmentosa, which actually has a footprint in East London. My family come from a cluster called the Fox family, which were extensive in East London. So we've been going blind in London for 150 years, my lot. And that people with that condition in London have formed a working age group that connects by social media, and its efforts aren't for themselves. I mean, they do gather in parks and pubs and wherever else is appropriate, but they use that as a referral point. So anyone that you know that gets RP, there's a place to go on social media and a Facebook group, and there's some other things that I don't fully understand, Snapchat. And I haven't used it so much myself, but my daughter, who has RP but is not symptomatic at the moment, has made connections there to people that are her age but have got the condition at a further point, and she's understanding real life. Now, admittedly, she's in a family of people that kind of get it and want to be a Londoner first rather than a blind Londoner. But it's that kind of thing. The thing I cite that as an example of good practice, and this is also true in the mental health field with Time for Change, where they've started to communicate the public health messages in a way that are meaningful to the way that people talk to each other and understand their everyday lives, rather than communicating, of an institution. We've never had anything as bad as those original HIV ads with the stuff down, but it's still, they're still quite great publications.
They kind of worked in the end.
Oh, they did, yeah.
Well, actually, I think one of the things...
As a part of the process.
Well, it woke everyone up, that's for sure.
Yeah. It also potentially flooded the system with people who weren't at risk. So I think it's just about having really sophisticated messaging. Yeah.
I just want to look at the perception of the public towards optometrists, right? For the Main Street opticians. How do they perceive them? Because do people think, look, this is the people I go for my eye health, or is it that this is the people who are going to tell me your eyesight is bad, right? And you're going to buy a pair of specs, right? I mean, what's the perception? Because I know that they have very sophisticated equipment, they can do tests much better than the GPs can, right? They have better assessment tools, and yet the public, right? My perception is this, that they don't see them as places to get eye health. So I just wonder what your feeling was.
I think that's down to me, isn't it? Yeah.
Well,
My other role is that I was president of the College of Optometrists.
Okay.
So I bet
All right.
declare an interest there.
Okay.
I'm also a member of the General Optical Council.
Okay, that's great.
It is shifting. There are schemes that now optometrists can do, and you may have heard of minor eye condition schemes. There is research that we did with Lambeth and Southwark, CCGs, where they put a minor eye condition scheme in place with King's and Guy's. And it was an integrated approach with joint working. And actually, Lewisham and Lambeth it was. And where they had Southwark in the middle, where there wasn't a minor eye condition scheme, that was the control. They found in Lewisham and Lambeth the referrals from GPs dropped by about 28% to the hospital. So patients were being directed from GPs to the optometrist, and about 60% were coming through there rather than going to the accident and emergency departments at the hospital. So it was quick access, it was really making some changes, and so as a result, in Southwark they are now putting those schemes in place, and in fact in South East London there's a minor eye condition scheme in every CCG, and they're now working to join those up. So that is a really good success story of how services have been integrated between hospitals and primary care. You know, it's not just glasses where an optician sees. We have a responsibility to look at the eye health of that patient and give advice and appropriate management and or referral. So from a professional side, we are just much more than just the refraction side in our profession, and it's likely to change.
And this message is getting out to the public in these areas.
Well, we have the Eye Health Week where it's promoted, and the college has its website which it promotes to patients. I think it's difficult, and what I've seen in areas of deprivation, you know, the tendency is that optometry practices are probably reduced because they don't see the need or put off for other reasons.
And the eye test, just as well, the eye test is mostly free, or do people pay for it?
It is for certain groups. Over 60, it's free to people with diabetes or glaucoma, and for people up to 16 free and up to 19 in full-time education. Between that, there is a private charge, unless you're on any income support or anything like that.
You want to say something, Helen?
Well, just I suppose I think that the picture, well, as David's alluded to, really the picture is mixed in some respects. In areas of deprivation, you know, as I've mentioned, the retail dimension does, I think, put people off. I think that there is something around. I think that the general public certainly. We did it was a study that was across the UK, so represented across the UK, and people certainly recognised that optometrists could detect a range of different conditions, and when asked they did say they were there they saw them as people who were there for their health and benefit, but I think the retail dimension is a barrier. There is no getting away from that. For some groups of people, there is just a sense of they have to ration their use. I've talked with groups of people who did quite a lot of focus groups, and people were talking about, well, if I need to take the kids for a sight test and they need glasses, I'm going to prioritise that rather than go myself. So I think it's a little bit of a mixed picture, and they're not the eye examination isn't necessarily automatically seen as a health check like if you go to the GP.
Yeah.
It's a mixed picture.
Okay, Liam?
Thanks very much. I think we've explored a bit about, I want to talk a bit about early intervention and screening. We've talked a bit about why early detection is so important for the treatment of eye problems in previous comments. But I just wanted to explore what's currently preventing the universal rollout of eye health screening for 4 and 5-year-olds, which I understand has been recommended by NICE. if we were able to achieve that absolutely everywhere, what impact would that have on child development and attainment? And that's primarily to Carol and David.
It's the National Screening Committee, not NICE, that recommend screening. The National Screening Committee has only recently recommended it as a population-based service. Just this year, I think, and it's just recently produced some tools to standardise the screening pathway and the service specifications for it, and information materials for patients and the public. And those are just under consultation at the moment, and they will be reported on shortly, I think, towards the end of the summer.
So it's still out to
at the moment,
consultation.
it's actually in process for being recommended as a national population-based service. That is my understanding. The actual website of the NSE is a bit in my, just personally, I found it a bit confusing. But the reason there has been this sort of interest in it is that previously it wasn't mandated, and there was confusion about who should be commissioning it, particularly from 2013 onwards, whether it was the CCG, whether it was the local authority, whether it was NHS England, whether it was Public Health England, who was screening it. And in October, or the end of 2015, around October, local authorities were given the responsibility to commission this screening service as part of the Healthy Child programme. And at the time, through the Clinical Council for Eye Health Commissioning, we did a Freedom of Information request to see what impact the cuts on public health funding at that time would have on this particular service. And at that time, in England, 55% of local authorities were providing screening for vision defects in 4 to 5-year-olds. And they also indicated that it would become more challenging as public funding for public health services were constrained. So I think the answer, that was a long answer to your question, but I think it's in going from something you should do to something that has to be done. It's in that process at the moment. But I think we should be wary of the fact that, although it's part of the Healthy Child programme, there are issues around how the public health budget within local authorities is prioritised as well.
Yes, I mean, my feeling, having read a few of the strategies that have been produced, quite often health seems to sit with adult care and health and not with children. And I do have some concerns about then the early intervention and screening, particularly for the young. But also, if you look at the preventative strategies, and a lot of local authorities have been developing preventative strategies, my feeling is that site issues are not sufficiently dealt with. There'll be pages about full prevention, but as we were exploring earlier, you know, if you're, and of course, as you develop a site problem, you might be more inclined to, not deliberately, but because your site has actually changed.
Yes.
So the fall might occur because your vision is actually in the process of undergoing
Absolutely.
a change. So I wonder whether that's been sufficiently flagged up in those preventative strategies.
I don't think it has, I agree with you. And I think I'll give you another example, which is from a much more established screening programme, which is the diabetic eye screening programme. The current eligibility is 12 and over. And the uptake is reported as a blanket of 12 and over. That's a huge bit of the population, and they're not all the same. Through the portfolio of indicators for eye health and care that was developed through the Vision 2020 Public Health Group, we identified screening uptake as an indicator, but specifically children and young people aged 12 to 18. So we wanted to break down that overall figure, just to recognise that they're different, not because they're little or younger, but very different needs. And this is a chronic condition, lifelong, and it's a challenging time during adolescence and young adulthood. So we included that to look at that specifically. And in doing that, this was a few years ago, in doing that, it aroused the interest of the National Paediatric Diabetic Audit, who then actually looked at it and reported that in 2014-15, that audit, uptake, just headline figure for England, amongst 12 to 18-year-olds who are diabetics, uptake for screening is only 65% compared to the 80-something% for the headline figure. And that was, oh, shock, horror, we didn't know that. Well, the data was there, we didn't look for it, right? And so David, through the London Eye Health Network, followed that up in London with NHS England, who did an audit of uptake in this age group from the screening programmes within London. And what they found in 2015 was that it was similar. It ranged from 67 to 89%. So overall it was the same as England, but there was variation within the screening programmes. And again, they just looked at it, highlighting for the programme in totality, and there were several. And so what we're hoping to do is take that the next step further and repeat that audit and look at the variation within the area covered by the programmes. There are 5 programmes in London, and there will be variations. We want to explore what those are. The reason for including it was actually not just because 12 to 18-year-olds are different to other adults, is that diabetes is increasing in incidence and obviously prevalence, and the incidence is occurring earlier and earlier. And at the moment, screening is just based on chronological age, whereas our understanding of diabetic eye disease complications in young people, children, and their risk for developing diabetic complications, the evidence isn't great, because until more recently, it wasn't something that affected very, very young children, and it is. So I actually wanted to get a feel for, should the recommendations for the eligible population change in due course if somebody's being diagnosed very early in their, 2 or 3 years of age.
I think I'm correct in my understanding that it's actually the prevalence of type 2 diabetes that's been increasing in...
No, it's
type 1 as well?
Yes, it is. That doesn't get the headline because the numbers are smaller, but it is, yes, our understanding of what type 1 diabetes is also changing as well.
Yes.
But, people are getting diabetes at younger and younger ages. So it's the duration of diabetes which is a risk factor for developing complications, not just your chronological age. So for all of those reasons, 12 to 18-year-olds were important, as well as managing their general diabetic care as well was an important group to look at. So.
And presumably also because they're younger and perhaps have less of an understanding or are very busy doing other things because they're teenagers.
And being a teenager and,
Exactly. Who wants to spend all their time checking their, blood sugars?
And we see that in hospital. I mean, I don't deal with children, but we see that in the eye clinics. You have young adults coming through who had a very challenging time during their adolescence and have had, horrid things happening to them. And you're just trying to, keep them treading water basically as well, and so they are different, they are overlooked, and you're quite right to raise that issue.
Yes, I just think it's worth reinforcing the point as well about the 4 to 5-year-old screening, in that the fact that 50% of local authorities in England weren't providing that routinely, that is appalling. And I don't have the figures for London, but it is something that we really need to look at, because it has a profound impact on children, obviously, if they don't have a sight problem identified at that age. And it's, the guidance has certainly recommended it from the outset. So it's important that we...
Yeah. And it's also, when you have it in place, that you have the appropriate pathways that follow that, because you've got to deal with those people to make sure, is it a refractive problem, or is it something that needs to go into the hospital because of amblyopia? And I think if you have efficiencies in those, it's really important, because otherwise you can get a lot of false positive referrals from screening that need to be, that you need to manage out of the system, because some do not need to be in a hospital situation to be there. They could easily go to the
So the point that you're making then is that not only do you need that early intervention and the screening, but that once you've achieved diagnosis, that you then need to follow that through, in some cases with specific treatments, or in other cases you screened and perhaps someone doesn't need something else, or they might need some sort of further interventions because the issue is linked to, as we were just exploring, diabetes and another condition.
Yes, and if people don't, if children don't get some of the treatment at the right age, then the condition... Yes.
Yeah. I think the other thing is fail-safe, and I'm involved in diabetic screening, and where you find people come to harm is because they fail to attend, and they fail to attend the hospital on being referred, and then you pick them up later, probably about 18 months if they haven't attended either appointment, because they get sent another, only to find that it's got worse since then. And some people might be in denial. There's lots of reasons behind this, but it's making sure in all cases of screening that fail-safe is also there.
So that's the sort of the negative side, and exploring what the difficulties are. What current initiatives are there out there in London at the moment that have been really successful in detecting and diagnosing and then treating sight-threatening conditions? And is there anything that the Mayor can do specifically to support any really good practice? And that is to all of you, but not at the same time, because that would be awkward. do you, Helen or Keith, to start with?
So I think one of the initiatives that we've been involved with is a partnership project with the Royal College of Ophthalmology, RNIB, the Macular Society and the International Glaucoma Association, and it's called Ask and Tell, and it's about patients being self-advocates. So once people have had a condition diagnosed, as we've pointed out, operating in the eye care system can be quite a challenge. And as in many instances of healthcare, patients are often quite reluctant to ask questions to their clinicians or the health professionals they meet, to chase up appointments, because they feel that actually, that's the doctor or the person who's on the phone or the nurse knows best. And they, it's a real sense of vulnerability. You want the best out of these people, obviously. It was actually this initiative was inspired by Carrie McEwen, who was the president of the Royal College of Ophthalmology, the previous president, and she was actually saying clinicians want people to ask questions. They want empowered patients. They want patients who know you've got to come back for your glaucoma appointment in 9 months. I need to see you in 9 months. Because often what happens is people might get that information from their clinician, or they may not have quite twigged from the doctor that they've seen. They've got to come back in 9 months. They go and they give their form in, and because of the system, they get an appointment in 12 months, and that gets cancelled, and they have to wait 18 months. This is extraordinarily regular, and people are losing sight as a result of this. So the Ask and Tell campaign is about encouraging patients to feel confident to say to their health professional, when do I need to be seen next? And then to go to the administrators, if they get an appointment that's not actually in the time period that the clinicians recommended, that they chase up and that they make sure they get that appointment. I think that's currently that's being piloted in Moorfields and in a number of other hospitals across the country. We're obviously refining that and improving it, and I think that's something that I think the Mayor could get really behind. And actually, if you have somebody like the Mayor who has a very high profile and is well respected, reinforcing to people that as a patient we have a right to be empowered, to ask for what we want, to ask clinicians to come prepared, and that actually it's about a partnership with our health professionals, and that health professionals often are quite happy for that, then that I think is something that has real benefits. I think we also need to be mindful of people with different abilities and different needs and different levels of confidence. So it's not an easy thing for patients to do, but it is something that we can, I think, really take forward. And I think we need to, given the challenges that we've got in the system.
So that's one example. Keith, I'm sure you've got an example other than the one you were just telling us about earlier.
Yeah, well, I won't go on about social media again. I think we'll fail there. It's understandable enough. But there you go. Yeah, I think one of the things that I think is critical is that the voluntary sector in London sort of gets real about what its role should be in all of this. And London has many good examples of local voluntary organisations that are promoting eye health and supporting people that have that have got life-altering sight loss or concerns about their sight. But it's very, very disjointed, very localised, and you've got a lot of different sort of tiny little boards all over the place. So in looking at it, we've because I'm leading what was Vision 2020 UK, but we're having a rebrand, but not just a rebrand, and getting organised and those sorts of things. But no, it's all right. It's not announced yet, so you couldn't tell them. But the point that runs through all of that is that I think the voluntary sector can be more than the sum of its parts at the moment, and particularly in London, partly in reflection of you know, how populations interact with Moorfields and their local hospitals, and how they understand themselves as a community that can support each other through, you know, eye conditions and around eye health. So to that end, we've got a modest amount of investment to create an umbrella body for London called London Vision, which will bring all of the charities that are active in London around eye health and sight loss into one place, which initially will be quite a noisy room. The effect of doing that must be that we achieve some clarity, and that we enable London-wide bodies to be able to converse with that voluntary sector about the role that it needs to place in relation to social care and colleagues in the clinical environment.
Is there something the Mayor could do to support that, coming back to the other part of my question?
Well, absolutely. I mean, my colleague Kathy
right.
is leading that piece of work.
That's going to be my point.
But we can switch straight from you now, Keith,
Yeah,
if
no, I
you
mean,
want
I think
Kathy.
it's, as Keith said, it's partly about the role of the voluntary sector, and that's what we're trying to, we're trying to line all of that up better so that we can ensure that there is equality of service across all parts of London. London, obviously, lots of different parts are very different, and different needs. But actually having some kind of consistency of approach so that, people, when they kind of come into the system, have got a really kind of clear route through to get the support and, the support they need to live their lives, but also to actually, just get on with their lives, really, and kind of keep in work and, keep their housing. And, so for me, actually, what the Mayor could do is just sort of recognising, sight loss and eye health, actually in other strategies too. Things around inclusive design, things around employment. As Keith said earlier, 75% of blind and partially sighted people are out of work, which is, really high and higher than other disabilities. I think there's a whole thing around, previous consultation that you've done has been about deaf and disabled. Blind people are also kind of part of that. It doesn't sort of seem to be, seen as a separate group or a group with that kind of priority. And then some other sort of practical things, and not sure what the Mayor can do about this, but things like having ECLOs in every eye hospital, every eye clinic. An ECLO is somebody that liaises between the clinical side and the patients and helps them access services, helps them move on to, the voluntary sector or to social care or, but we've got about 60% coverage in hospitals in London, and that's a really, really important role and saves an awful lot of money for people, actually. So I think the RNIB have done some studies recently, and for every £1 that's invested in an ECLO service, it actually results in a saving of £10.57 to health and social care. So it's a really phenomenal resource. And then just in terms of a good initiative, we've done some work with an organisation called Vision Care for Homeless People, who actually take eye testing to homeless centres and actually tackle that kind of, really, really hard to reach community, actually. So.
Okay.
Do you mind if one of the things the Mayor could help us do is, if we do manage to get ourselves organised in a coherent way, when we manage to get ourselves organised in a coherent way, that you could help us, help us get those clear messages, out there to Londoners. And another point, a practical point that I wanted to make, that there's to learn to use one of these is one of the critical things for somebody who's got life-altering sight loss to a skill. It's a critical skill to have if they're going to get around and play a full part in the community. Now, as it stands, learning to use one of these generally comes from a referral when you get your certification of visual impairment, which will then be passed to a local authority or whoever holds the register for visually impaired people. For a lot of people, they're diagnosed with conditions that kind of get worse as they go. And I think for elderly people, that particularly with AMD, you can be diagnosed with it, but your life experience over a year or 2 years prior to any kind of certification will leave people at times, not always, but at times out of that pathway, and so not able to learn skills with these things that are great to learn when you can see a bit more, so that your confidence is there when you get in. And I think that if you think, when you receive diagnosis of life-altering sight loss, a lot of things go on for an individual, including they can find themselves out of work, find themselves isolated, puts pressure on families and all of those kind of things. So there's a lot to absorb in terms of information at that critical point. One of the things I think we're going to try and get the voluntary sector together to do, and working with clinical and other colleagues, is to make sure people are using these things and getting out, you know, in a better and so when I'm saying we're going to clarify some messages, it will be not just get people using white sticks and moving around London, not something that's perhaps more, you know, up in the air, sort of strategic type things, just dead practical things that will help Londoners, you know, enjoy the city, you know.
Just,
David and then possibly.
I think London really, you've got world-class organisations delivering world-class treatments to patients, and they're doing a fantastic job. I think we should be looking at the positives in this. I think then the system is not helped because of the fragmentation that goes on, and it will only work together with greater integration between clinicians in primary care, so they do more, have a greater understanding of the hospital systems and what they need to see, and it extends out into the charities as well. So you can see that the money that is being spent is massive. It covers the whole range from primary to the end stage. And I think what we can do for patients is to make sure the whole system joins up so that they know where they are in the system, and they know who to ask if they cannot find their way. I think from the mayor, we are looking at getting London data through the portfolio of indicators, and some of that is really tricky to get. And support and interest in receiving that data. This is the UK Vision 2020 portfolio of indicators. And support and interest in getting that data and be interested in that data would give a snapshot of what's going on in London. And the other thing would be a development of a system-wide London strategy to bring all of this together, because as you see, we're a wide-ranging group who are all committed to make things better for patients. And I think we just need support to bring all this together, because at the moment we are finding we're doing good things in bits, but there's so much that we could do more if we collectively did that.
What's stopping you?
I think where the problem is at the moment is all the money comes in different pots, and how do you have a view of how do you make the decisions and the pathways?
I understand that. What's stopping you talking amongst each other?
We are.
We do.
We do. And a few years ago, you know, I chaired the Clinical Council for Eye Health Commissioning for England, and Powell is the vice chair. We've got a lot of expertise. We are working together across multiple organisations to make things change. The decision makers are not necessarily the people in the room when we are working together.
Okay. Thank you.
Did you want to add a final point? Briefly, yeah.
Okay, very briefly. I think what works well within eye health and vision health is that there's excellent collaborative working across healthcare and the voluntary sector. And we do that really well because we're passionate about it. But not just because we're passionate and we just like to talk, but we actually do things, and you've already heard some examples. I won't repeat that. I think the other thing is that we have done something about it. Through the Clinical Council, we have produced some frameworks for commissioning to make sure there's some standardisation and governance and accountability around commissioning pathways and moving care from hospitals into other models of care as well, where there's been a gap but nobody else has been interested in doing that. We've got on with it, haven't we, and done that. So what do we do? What stops us is that we sort of have to do it on our own. We don't mind doing that, taking the initiative, but sometimes when you've taken the initiative, you do need some support from the wider system in order to enable it to actually then happen. And that's where sort of our barrier is. So what would I like from the Mayor? Okay, I think what I would like from the Mayor is for the Mayor to commission a report on the eye health of London. And I think that would provide the baseline for all of these other things that we're talking about. And it could be a wide-ranging, encompassing thing. We'd have to agree what its scope is, but I think the portfolio of indicators that we've talked about will be a very useful starting point, and then we could engage with others to make sure that it truly reflects all the perspectives that we need to understand how we are right now, and also to look at what information we would need to inform future short and long-term developments as we move forward in the next 5 to 10 years. So I think that would be a great thing that the Mayor could do. David's already alluded to the sort of standardised commissioning strategy, but my last thing is to promote a site-friendly city. And there are a few things that I think the Mayor could do, which is around transport. It's not bad, actually, with the talking bus stops and things like that, but it could be a lot better. The urban street environment and street lighting and all of those other things. And I think to improve the opportunities for sight-impaired people for sport and recreation facilities, you know, especially following our Olympic legacy. And the final thing is digital assistive aids. They are transformational. My patients couldn't do without them. But the trouble is, you need to know where to get them, what's available, accessibility and affordability, and because the technology is becoming much more accessible, because it's coming, you know, it's cheaper. That I should not have to send a patient who I've just certified to the low vision aid assessment clinic, who will come out of, you know, the centre of the universe, which is City Road and Old Street Roundabout, with a handheld magnifier. If they're really lucky, it will be backlit. In the 21st century, you know, the digital assistive technology is the most transformational thing since Braille. Would you agree? You guys?
Absolutely.
Since Braille. And it enables...
There's a lot of nodding going on.
Yes.
Shall we keep going?
No, because I you know, see, not them, but I talk to them all the time. And it enables sight-impaired people at varying levels of sight impairment, from certifiable and registrable, like severe, to people in the middle, to actually get on with doing what they want to do slightly differently. They're using gizmos that everybody else is using, so there's no stigma associated with it at all, and doesn't put them at risk or make them vulnerable in a crowded situation as being different or having a disability or something in busy social situations. So that's important. So those are my 3 wishes, please.
Well, thank you all very much.
Good. Andrew?
Thank you. Just to finish off that way, you would basically want everywhere to look like the immediate environs of Moorfield.
Oh, please, God, no. No.
He used to be good. He used to be very prominent signs, very prominent signage for people with poor vision. It seems to be less so nowadays than it used to be. Is that? Am I right in that perception?
No, actually, no. We have spent quite a bit of money to improve the signage within the hospital. I think it's. The hospital at City Road is a very old building.
Yeah.
The other sites that Moorfields works at are much better in terms of, you know, accessibility for sight-impaired patients. But there is an issue generally, I think, to be aware that, and it's just putting on the list of things for anybody who has an impaired function to be able to get around our city and enjoy it. You know, as best they can. You can't cater for every single thing, but we could. There are lots of opportunities we could make it better. Talking to people like Keith and Kathy and others, and the RNIB and others, as to how we could do that. I think would be important.
So, just back onto my main question is: what is the impact of the rising numbers of people with eye health problems having on the healthcare system in London? What's happening as a result of that?
Well, I think that is the capacity crisis that we've been talking about. I think what it means is that people are having delayed appointments and losing sight as a result, and sometimes irreversible, that they're living with sight loss that could be treated like cataracts, but they're not getting timely access. That they are actually, people are getting lost in the system. Where their hospital appointment is being cancelled, and if they're not confident to chase it up, they are quite literally getting lost in the system. And there are examples of good practice where hospitals and so on are challenging this, where good audit is going on and people are being prioritised. But as David made the point, I think, about new treatments, ageing population, increases in diabetes and so on, there's an increasing demand. I think that one of the things that we don't talk enough about is the fact that the NHS needs more resources. We're almost in a situation where we talk as though there is a finite pot and there's no point in talking about solutions that require more funding. But actually, I think we have a responsibility to say more funding is needed across the board. It's not a case of taking it from this specialism to eye health. It's about having more investment, because health is an investment for our population. So I think that's one of the kind of big issues.
Thank you. Mr. Sun.
In terms of your question about what the impact it is having, people who couldn't, we can now treat people who had previously untreatable conditions, and that's a significant innovation in the last 5, max 10 years. That means that we can treat more people. And epidemiological modelling would indicate that even if we had the best case scenario where we had highly effective interventions having good outcomes that we all think are good from different perspectives, and there is a high uptake of treatment, so the services are there in a timely way, even if all of that was happening, epidemiological modelling will tell you that the numbers who have severe sight loss and impairment, who are registrable, that those numbers would still go up for the common causes of sight loss in adults, simply because of the ageing, the shift in the structure of the population towards ageing. So the numbers, that's why I started off earlier, the numbers are big, and they're not going to get any smaller. So so everybody who comes to this committee is going to say the same thing to you. The numbers are big. So we're just on that same list, the numbers are big. But I think the capacity issue it's coming to a point where, we have patients who we have to give new appointments timely, but then the follow-ups are then are affected because you can't squeeze them into the slots. I think the other thing, and it's not just eyes, is an issue around non-attendance for any health appointment, whether it's in GP practice land or in the hospitals or wherever. Non-attendance is high, and that adds to the pressure on the system to rebook those patients who did not attend within a reasonable time frame. Now, whilst we sort of struggled and managed until more recently, it's got to the point where we just can't manage anymore, and that's why we're seeing patients with delayed follow-up and actually having reportable instances of harm to patients, in that their disease status has progressed or they have actually lost vision. And that's through the work that the Royal College of Ophthalmologists has done recently. So that's the impact. But I do think in terms of empowerment of patients and the public at large to understand that we have these pressure problems, but attendance is actually really important. I'll give you an example again from diabetic patients. Those of diabetic patients who are referred as urgent or routine, they've got to be seen in the hospital eye clinic within a certain period of time. Now, so the trouble is, even if, I can only give you my figures from our hospital, that last year we provided those appointments for urgents and routines for referrals from the screening programme. 99.5% of them got them within the time frame, so that's pretty good. But the non-attendance for those was around 35%. So we then have to find those 35% of non-attenders, rebook them again really, really quickly, and that there's a perverse implication then on other referrals, new referrals. They have to wait a bit longer, and as I already said, the follow-up appointments get put back or delayed as well. So the flexibility or the...
You think diabetic patients are not turning up at appointments?
For new referrals, it's a new referral.
Oh, for new referrals.
But I'm just giving them as an example. I'm not pointing a finger. It's just an example.
It's just one of the things with regard to the links. This committee did a report not so long ago about diabetes in London, and one of the positive things was the way in which diabetics are being encouraged and generally successful to manage their own condition, and it seems to be generally successful. But I'm getting a contrary message here, that actually diabetics aren't looking over that part of their health which is at risk from their condition.
I think part of it, and I have no evidence to support this is just a personal opinion, is that the eye problems amongst diabetic patients are not seen in totality of all their other care processes. It's seen separately. It's reported separately, it's managed separately, and so they've got to, it doesn't fit into what else is happening around their general diabetic care. That's possibly a reason, but I can the issue around non-attendance. It's not just unique to people who have diabetes in Ireland. We do have an issue with non-attendance generally, and I think all I'm saying is that there are lots of very good reasons why people don't come up, and very not so good reasons. But at the moment, we just don't have the flexibility to book them back in again.
Let me say that, Dr. Sarah, this non-attendance, right? But then there's also the pressure, right, of a doctor's clinic gets cancelled because the doctor's gone on holiday in the local important.
Yes.
And then the other problem, of course, is once you have one DNA, right, they get struck off the hospital system all entirely. They've got to go back to the GP again to be put back in the system again.
Yes.
And that adds further delays to the problem system.
So it's not just the patient, there's a system-wide thing here. It's a multifactorial thing, which whilst before we just muddled along, we got away with it, right now, because everything is rising steeply, activity is rising steeply, we just can't accommodate it, and the seams are bursting.
Yeah. Just one point, we haven't touched on workforce, and things are changing. Where you go to the hospital, you might be seen by an optometrist or an orthoptist or a nurse practitioner rather than an ophthalmologist, and people are working more as a multi-professional team. Last year there was agreement on a common competency framework for all non-medical practitioners working in a hospital environment, so that what could be expected, irrespective of your profession, was agreed. And I think this is a way forward for a different way of working, and I certainly within the Royal College, they are quite concerned about the fact that there's not going to be enough ophthalmologists to deal with everybody in the future.
But there aren't enough GPs, there aren't enough anyway.
Absolutely. So the limiting. So we've got to look at new ways of working, virtual, telemedicine.
How much is that affecting the? I mean, to what extent has that innovation been introduced across London?
It's slow, I think.
So there's something that can be done.
There's pockets.
There are things you can do. I mean, at Morpheus, we have moved from doctors providing the treatments for age-related macular degeneration and diabetic complications through injections. We've shifted from doctors doing that solely to having nurse practitioners doing that. And that's made a huge improvement for the patient. They don't have to wait and get timely treatment. But we can actually give people their appointments and their treatments as they need them in the right intervals. And without that change, we would not be able to do that just with doctors.
Yeah, I'm a bit of a fan of Moorfields Eye Hospital, I must say. My husband had a problem with a detached retina, and the treatment he got there was just absolutely jaw-droppingly fantastic. I've never known any treatment like it before. It's wonderful, wonderful. So fortunate to have it in London. Sorry, Ms. Lee, did you?
Yeah, just a couple of points. I think the point that's been made around the complexity of diabetes, it's a really difficult condition for people to manage. And when they have lots of other things going on in their lives, bereavement, job loss, whatever, then actually attending your hospital appointments can be one of the things that gets dropped off. Just in terms of, people need support, and I've talked to many patients and clinicians who say that people need more support to manage their diabetes, because it is a difficult condition. So I think we need to look at that holistic
And
support.
furthermore, if you don't manage it very well and you become hyper or hypoglycemic, it also actually can make you quite confused.
Yeah.
So
Yes.
in itself, it becomes difficult to manage, and then you can also be confused inside that difficulty. And I think that's insufficiently acknowledged.
Yeah.
The level of difficulty just from not being able to balance the sugar levels, and it doesn't matter, but sometimes up and sometimes down, it does create that.
Yeah.
But that's just speaking, as a
Are
lay person.
you saying? I mean, there's sort of an indication here that we need to rethink the way in which we're supporting people with vision problems, not always directly to a professional ophthalmologist. Sometimes it can be somebody else providing that support.
Absolutely.
And that provides some of perhaps a little bit of a get out from the problem we have with the sufficiently qualified staff.
Yeah, no, it's absolutely. I think that idea about the finding out what's needed and finding the person with the right skills, the right competency doesn't, previously might have been a doctor, now it can be another health professional. If they've got the right skills, they need to deliver it at the right time and the right place. I did want to just pick up the point about non-attendance and hospital cancelled appointments. I think the reason I mention hospital cancelled appointment is because there's a lot of evidence that is a real problem, and anecdotally and just audits indicating that patients getting delayed appointments when things really need to happen at the right time, because the administrator who's making that appointment doesn't realise how crucial it is that somebody's seen at 9 months or 2 months as opposed to 18 months. And then when people are having hospital appointments cancelled because the clinician has to reschedule their appointment or whatever, then they kind of can get lost in the system. So I think it's back to the point that Carol's made and David's made, that it's a systems issue. And I think it links to the point that has been made about awareness. Eye health isn't on the top of necessarily the public's agenda, but also it's not at the top of commissioners' agenda. And that's where the mayor, I think, can have a real role to play. It is about prioritising eye health, showing how the impact of addressing, improving eye health, what impact it can have on lots of other conditions, and what and the problem that it has by not addressing it, how it can actually compound problems.
There's a lot of reinventing the wheel. We've done a lot of work over many years to say what needs to change, but everybody is coming up with different solutions again and trying to do it. The fundamental principles that the Clinical Council for Eye Health Commissioning has put forward is risk stratification of the whole eye health and sight loss pathways. So only those who need to be referred are referred from primary care. Community eye care should be for people stepped down from the hospital to release capacity, not triaging stuff going through. And those who need to be seen in a hospital need to be seen there and on time. And if every part of the system works well, that is what we are working towards. Because if one fails, or it needs the whole pathway to be complete and work efficiently and to be integrated to make things happen. And that is where we're coming from as a sector. We speak now as kind of one voice in what needs to happen. It's those who can make it happen now really need to take some of these messages and make it real.
The best and the worst performing CCGs with regard to referrals are all in London. Why the disparity? In terms of treatment times. Well, all right. Great silence there. We've got Hackney and Croydon and Barking and Dagenham treating within 30 days, and we've got Enfield that takes 467 days. Now, what on earth is happening at Enfield? Which looks like it's surely got to be something wrong with the figures rather than wrong with the service, I think. But what is happening there? Why is this huge disparity in London itself?
Is that the time from referral to treatment?
That is.
Cataracts. Is it cataract? Probably just the cataract.
Yeah, cataract surgery for the average waiting time between the first appointment and cataract surgery, right, was 129 days. The best performing was in London with Hackney and Barking and Croydon. The worst performing was in Enfield, and quite a long way behind. Similarly poorly performing was Havering. Now, why is that? What's happening in London that we've got this huge variation?
to do with the older population? I don't know the answer.
I don't know. Well, we need to further investigate.
Yeah, what I think you've identified there is the cataract referral. And
sorry about that, I should have specified that.
So I think some hospitals are, and some CCGs are prioritising cataracts while others aren't, because they're having to prioritise or choosing to prioritise other treatments, which goes back to my point about actually there is only so much that can be done within existing resources. We do need to call for additional resources. I think that.
But you see, that's an argument that you can use in Enfield, but you can't use in Hackney.
I think the important thing is the NHS standard.
I mean, I could understand if it was like double the time. It's 15 times the time to get referred in Enfield as it is in Hackney.
Yeah,
There's something wrong there.
The NHS standard is 18 weeks from referral to treatment, which is about 126 days.
That's right. It's 129.
Yeah. So that is what within the Constitution, the rights of the patient to be seen within that time, and I think it's often the other demands on the system for other treatments, and which is more priority. If you have a lot of people with AMD who need to be seen within a very short time frame because sight loss is critical, they might prioritise because of that, whereas cataract may not be seen as permanent sight loss, temporary sight loss, but it is an inequity.
Is the 18-week target still an operation?
It's measured.
Is it still measured? So people are still getting treatment within 18 weeks, or meant to?
Meant to, yeah.
I think that's one of the reasons why there are occasions when we will identify particular authorities that are not delivering an adequate service, and in many instances clinicians and service providers will be getting together and looking at how that can be improved. But I think what we at RNIB have done over a number of years have realised we can't focus on just one eye condition and say, look at the treatment here, look at what patients are receiving, for example, for diabetic eye disease as opposed to cataracts, because what we need to say here is there is a capacity problem across the board, and that needs to be addressed. That we need to find solutions.
Well, you say that, but it's the disparity, because if you're living in Hackney, you don't see that. You see a really good, or Barking, as I do, you see a really good service, very quick turnover. So the argument isn't, it's all about resources, because if you live in those boroughs, well, actually you're getting a good service.
I think the point that David's
the
made...
generality, I get the point, generality, it needs to be better.
But also the point about different, CCGs may be prioritising different eye conditions, and there is a rationale for it. It's not one we would support, but it's those decisions are being made.
Sorry,
I think a way to look at that is to drill down to another factor, which is what are the rates for cataract surgery within those CCGs. The NHS Atlas of Variation a couple of years ago, its most recent iteration, included variation in cataract surgery across CCGs in England. And across England, there is a 3.5-fold difference in terms of the rates of surgery per 100,000 of the population at risk, and that would be people of 65 years of age and over, who would be at risk in their lifetime of needing a cataract operation for a cataract that was visually impairing. So if the rates in Enfield are lower than in Barking and Dagenham, age-adjusted rates, then there is a problem. Then patients are actually maybe having an issue there that's worth drilling into. So whilst that is as an indicator, it needs to have further information to actually say, is there some inequity going on here between Enfield and Barking within London? I think just looking at that figure can't give you an answer to that, really.
It is interesting that my understanding is Enfield's currently having a consultation about what they prioritise in terms of healthcare, and deprioritising cataracts is on the agenda.
And the sad thing is, cataract.
Deprioritising
Yes,
and
the
they seem
sad-
to have done that already.
Yeah. and the sad thing is
It's
that
going
actually
to get worse.
for the last
26 years.
for the last 20 years, commissioners regularly, cyclically almost, have meetings about procedures of limited effectiveness, and on that list is cataract surgery. Not because it's a procedure of limited effectiveness, it's the opposite. It is actually the most effective intervention that we have within the NHS.
Forgive my total medical ignorance here, but I rather thought the cataract surgery nowadays was a bit like shelling peas.
No, it's not.
But
It
that's
is
the
not.
impression
No,
that certainly has been promoted.
no,
These innovations taking place
no,
in
no,
India, for example.
No, it
where
is
they're-
not. No, it is not. We don't live in India. We live in London.
No, I know,
And-
but
and it
where
is not.
they're setting up as
No.
almost factories
No,
for
it is not.
queuing.
I will tell you again, it is
Okay.
not. It is only appears to the public at large that it's like shelling peas or getting your hair done
Yeah.
because of the technological skills in the biomaterials, the equipment, the surgical skills and the system around the operation that enables a person to walk in the morning at 8 o'clock, have their cataract done, go home at lunchtime and have their tea or go out for dinner in the evening if they wanted to, or go and socialise. That is what the success of the NHS is in delivering cataract surgery to people who are usually of 65 years of age and over. The average age of a cataract patient is around 74 years of age, male or female. And that is the success story. The complication rates are very infrequent and manageable if they do need to be addressed. But really, it is the most successful operation in the NHS. The reason it's picked on, I will tell you, is because we do so many of them. It's because we do over 350 to 400,000 cataract operations a year. And the numbers just do this for the last 25 years. Because more of us are getting older and more of us need them, and the technology is better so we can intervene earlier, so that you're not disabled by it. We can carry on driving our cars safely and be independent in our old age, and it works. And so the reason they pick on cataract is because we do so much, so many of them. They think by reducing it and playing with thresholds, they're just nibbling around the margins, and it's false economy and actually could do harm and impair the well-being of patients who have a sight-impairing cataract.
And
So
in
what
terms of-
so that, I didn't quite get that last bit. You're saying by
By picking on cataract and imposing draconian thresholds, or even restricting the volume of activity for cataracts in a year in
I see. In terms of the rational, because that moves very much on to my next question, which is I think you've effectively answered anyway about rational conditions.
Just going to add to the point that Carol was saying that the brilliant system that we have around cataract treatments is reliant on having consultant ophthalmologists who can identify those people for whom cataract operations are problematic. And while for the majority of people they are very hugely successful, it is that specialist knowledge that is required to identify. Mike Austin, a consultant in Wales, has an expression, spotting the rat. And the rat is the person who is not going to have a cataract operation very easily or successfully, where the risks of sight loss are huge. And just having met with patients for whom that's true, it's about the effective system that is crucial.
And the other factor is that about a third of people who at any one time go to have a cataract operation, they will also have some other problem with their eye. And again, as we're living longer, we're more likely to have more than one thing wrong with our eye when we have our cataracts done. So they're the people who do need to be, not a complicated pathway, but it's just not the routine, straightforward one. A third is quite a big chunk of somebody with having multiple ocular morbidities having surgery. And
you have groups of people with glaucoma may often need a cataract operation to relieve the pressure.
To manage the glaucoma,
yeah. So it gets really, really confused.
Can I make
I get the impression I beg your pardon, Mr. Bannon.
Sorry, I didn't mean to talk over it. It's kind of a parallel point, but I think it's pertinent on the fact that there are variations in the eye health and sight loss pathway for Londoners. There are variations borough by borough in a number of locations, and I make no presumptions about what's going on in the clinical figures that you stated, but certainly the work we've done over the last couple of years looking at how people make that transition from a diagnosis of life-threatening sight loss into you know, the kind of support, be it a stick or, you know, emotional support to cope, those sorts of things, is quite wildly varied from the anecdotal evidence that we've connected. So, for example, in Kingston, you can expect to be seen quite relatively quickly with a relatively good feedback on the quality of the service. In an area such as Brent, they went for quite a long time without any specialised rehab staff available.
Do you get an impression that these CCGs are talking to each other about the different challenges they're getting? Because, you know, in many cases you can get the high and the low in neighbouring local authorities, and you think, do they ever talk?
No. And that is why, if we have a look at a pan-London review of what's going on across London, would be really helpful, because they may be talking to themselves, just like we do in hospital. We just talk to ourselves and do our audits. There's no platform or there's no opportunity to discuss or share our findings, to get a view of what is the bigger picture. And that's why I think a pan review on the eye health of London would be very useful.
Yeah, I've started having with the Eye Health Network, having meetings in South East London, North East London. We have 30 people in the room for each meeting. We've got trusts, we've got commissioners, we've got optometrists, orthoptists. It's really been taken on, and we're having some really good discussions. That's what needs to happen in all 5, and then collectively across the whole of London, in broad terms, to share information between each of those particular STP areas. So we are working on it, and there's a real commitment from all the people in the pathway to make it happen. It's just some of those trigger points need to be clicked.
I think
Clear
Thank you very much. Oh, yeah.
Mr. Valentine,
Did you want to come in? Sorry.
well, not quite to repeat that point, but to extend it as well, that there's something about how, I think what we're all reaching for is how we set, you know, our aspirations and targets for Londoners, so that we can get some traction on change where you've got those variations. And it's I think for the partners that we're putting together at the moment, the work that David's doing there, it needs that extra London-wide kind of statement of intent, if you like, to help us do the things that we can do within the resources that are available, and then identify, as Helen's saying, whether there are areas where, you know, it's a question of resources. And I think that, you know, that point I made about the connection into, you know, into social care, I think it's reasonable to have expectations for Londoners that wherever they are, they've at least got a basic, you know, I can expect to have this done in any given period of time. And I think that's something that we could do that would make us greater than the sum of our parts, with the help of the Mayor.
Yeah, I've taken this to the London Senate, I've taken it to the London Clinical Commissioning Council. There's broad buy-in, but this is a kind of approach that we put together with a large group of stakeholders about what needed to change in London. It's just getting it higher up that agenda, and a mayor's voice to add that would be really helpful.
I mean, without making a political point on the matter,
But you're going to do it.
but I am going anyway. Of course, one of the things that one does hear about is how we've got 32 CCGs, right? Okay, and that you have been alluding to all the time. But if there was a pan-London mechanism, right, or a sub-regional thing, I think you may have already answered it, but I just wanted to ask a question. Would we get better outcomes for
I think the answer that, well, you need to know what it's like now,
yes.
in order to know whether the outcome is better or not.
Tell us what's like now.
So you need to know what's happening now, what the outcomes, what it's like now, what are you getting from the health and care services. Because Keith's point is actually very important. I'm just going on tangent for a wee bit. Whilst we have standards and things, and we monitor health and services, for social care, you know, we have none of that, and there's huge variation in terms of timeliness, etc., and what support is provided, not just for people with sight impairment, but just generally. So we do need to address that, and eyes are a good model to look at that in more detail, because it's quite specific. So I think you need to know what's happening now, what the gaps are, in order then to inform what that strategic approach should be, and then you can review it back again afterwards, so you know that it's a better outcome or not, or an outcome that you hadn't actually expected, which could be good or bad. So you have to have an. So I think you need the two things go hand in hand, really.
And we need a commitment, I think, from those who've got the money, that they'll listen to what we were saying. So we need to, you know, rather than recreating groups of people talking amongst themselves within the eye health sector, which we're now really very good at, and having identified some really good solutions. I think what we need to do is push it up the agenda of those who are commissioning, who are having to look at a whole range of different issues, and that's where we need support and clout.
Yeah, just one point, just an example. Each CCG is developing a service specification for primary eye care for their own group of patients.
Each CCG is doing
More, yeah.
Okay.
But patients don't stay within their CCG area for their eye care, and therefore, if you could have a primary eye care service specification for London, do it once. It's not different in any place.
But what's preventing these 32 CCGs getting together and sitting down?
Well, they are starting to do at STP level.
Okay.
And I went to the Clinical Commissioning Council, and the chair said, get a service specification for London. But what we did do, we got a service specification for England, and that's the primary eye care framework that the Clinical Council has done. So I did it for both.
Mm-hmm.
So it is there. It needs to be implemented.
That's about the implementation phase, isn't it?
Yeah, I think they're kind of hoping we'd go away and do it when they ask for us, but when we say, here, we deal with Blue Peter, here it is, they're sort of caught a bit short.
It is there.
It is there, yeah.
Great.
So if the mayor were to convene these CCGs into one place and make them, lock them in a room, lock the key and throw it away for a while, do you think there would be some benefit just to make them talk to each other? Because it sounds to me like everybody benefits. It isn't going to cost anybody any more than they're paying already, because they'll just be acting smarter. That's what I hear you telling me. Am I right in that?
There's duplication in commissioning, in delivery, and it's how we then get that different. In Scotland, as I make the point again, they commission it once. And all these different schemes that we've got are done through one contract. They've turned off the hospital A&E departments. It's all through optometry if you've got an eye problem. Optometrists can manage eye disease, eye conditions out there. They can see a patient again for a follow-up appointment if needed. They can manage all those different things that can stop the referral into the hospital. They've just done a community report from Scotland where they've identified that the increases in hospital activity has been about 13%, whereas in England it's around about 30% over the last 5 years. And they've done it by improving the capacity within primary eye care to manage that change.
And can the optometrists there refer directly into the hospitals?
Correct.
They can, without again.
And it's patchy here in London and in England generally.
Yes.
Some places do, some places don't, for a variety of reasons.
So it's consistency of approach. And when you think of all the trusts, the trusts have to deal with multiple CCGs in order to, and they can't identify the patients coming through the door from one CCG or another. So it makes sense to have consistent service specifications where there is benefit for everybody to do that.
Okay, thank you. I mean, I think I've answered all the questions that we had answered. But I mean, this is an opportunity for you. We'll go round, right? If there's something you think we should have asked you, and we haven't asked you, or something you wanted to say, that's one thing. And also afterward, if you think that you would like to add something to our investigation, write to us, or you have come across something which you think would be useful to us, you're at option. You can do that still. Okay, so this is not the end of it, right? Okay, that you can still send things to us. But here's an opportunity for you to say anything you want as in conclusion, to sum up things, and or something which we should have explored when we didn't. Do you want to say something?
Well, first of all, I'd like to thank the committee for giving us the opportunity to come here and speak to you and present some of our stories, and for the consultation that you've got on the website as well. So thank you very much. That in itself shows that eye health is being considered at least. So I think that's a great thing. I think you have had a broad range of questions. I don't have anything else to add apart from what I've already said. But eye health and vision is a life course issue. It's not just for when you're old or young. It's throughout life.
So just to say, we've got some world-beating services in London. It could be better though, and it's how we make things, how we make the system work more joined up, because I think at the moment we still have fragmentation there, and patients get in the middle of it all.
Helen?
I think I'd just echo thanks very much for raising the issue and inviting us. I guess I really look forward to seeing what steps the Mayor takes, what the next steps are. I think we as a sector are working together. There are a lot of opportunities where we can, with one voice, about the solutions, and we would really, I think, like to work in partnership with the Mayor around this. We could make, huge improvements.
Yeah, thank you. Keith?
Yeah, just to say that we're taking real practical measures to get ourselves organised efficiently, and so that we're able to deliver change, particularly my recent experience in helping the voluntary sector get sorted out. We're trying to make this work in a way that's clear and makes sense to Londoners, and I think any help that you can give us in taking that message up from along the pathway so that it can be heard louder in the CCGs. But I think also, speaking as myself as a visually impaired Londoner, those people that can't be cured, and treated, there's 32,000 people on the register in London. There are many more that have got life-altering sight loss, and whilst many of them are older, there are a good number of them that are just like me but not able to work. And so the eye health part of this is absolutely fundamental and critical. But for those that can't be cured, that transition out into living a full life and being a citizen is really critical. And so we're all on a journey. You have to have a journey, don't you, in these things?
Thank you. And Kathy?
I just really thank you again. Really like to kind of carry on sort of discussion and the sort of the working together, really. But I mean, it just really that actually it's not about patients, it's about people, and people who are partially sighted, blind, who have eye health issues. They are also people who work. They are also people who need access to other services and so just that whole kind of joining up really of any strategy, any kind of approach for London and for Londoners is actually about it joining up. It's holistic. It's holistic with people.
Okay, so thank you very much for your contribution. I'm just going to go through this bit of formalities, right, and then we'll wrap up in the next couple of minutes. Can I thank the guests for the contributions? And finally, can I ask the committee to agree the recommendations and delegate authority to me as chair to agree any output arising from these discussions? Thank you. Can we please note the work of programme 2017 and 18?
Noted.
Please can the committee note that the next meeting will take place on the 12th of September 2017 at 3 p.m. in the Chamber of City Hall.
Noted.
And as there's no urgent business, this concludes the meeting.
GLA, Committee Room 5, Sound.